Reporting for Heart Rhythm TV, I'm Mehak Dhande, and I'm joined by Dr. DJ Lakkireddy, cardiac electrophysiologist and executive medical director of the Kansas City Heart Rhythm Institute. Dr. Lakkireddy, thank you for joining us.
Thank you, Dr. Dhande, for this opportunity to chat with you today.
Of course. Now, on this episode of EPNomics, I'd like to discuss the importance of institutional care pathways in improving patient outcomes and decreasing healthcare costs. So for our viewers, could you please elaborate on the very successful ER to EP study and its main findings?
So when you really look at the complexities of patient care navigation, I mean, you would realize how complex it is even for a country like the United States, where we have, tremendous access to healthcare resources, and we are probably spending a lot more by many multiples compared to any other nations in the world on healthcare, that we still are not there in terms of really providing a high quality of care. While for many decades, the focus has been on inventing and discovering new drugs or coming up with new tools for ablation, both at a micro, macro level. One of the things that I realized as I was going through my master's in business administration was how little we focus on the process of actually providing the patient care, right? So this was one of my pet projects that I did, looking at what are the gaps in a patient's flow from the time they start their initial visit for a medical problem until it gets resolved, or until they get a plan to really manage that problem in the long term. There are so many steps, and there are so many hurdles, and there are so many places where patient care breaks down. And how do we really fix that, right? So I sort of took the atrial fibrillation patient as a model, and we looked at the number of steps that are involved in, right? So when you look at it, a patient has atrial fibrillation, they have palpitations, they're worried about it, they think they're dying, they go to the emergency room, the ER physician sees them and gives them a prescription and tells them, okay, call your primary care physician. And the patient goes home on a script for a medication. Oftentimes, they may or may not fill that prescription. By the time they get into their primary care physician's office, it's 3 or 4 months. And by the time the primary care physician decides to send them to a cardiologist, that's another 3 to 4 months. And by the time somebody actually gets a referral to an electrophysiologist to really do a curative fix for the problem, it's more than 12 to 16 months. In the meantime, they have had a stroke or a TIA, they had an episode of heart failure, multiple hospitalizations for atrial fibrillation, and a stroke or a bleeding complication from the anticoagulant. When you really look at it, for a patient who is unfamiliar with the medical field, to really navigate this complex web of things, it is super difficult, right? So this is when we thought, okay, how about we really cut out the middleman and really help a patient to get in front of a cardiac electrophysiologist for the specific problem that they are dealing with, right? That is the origin of the ERTEP, right? And so how did we do it? So we took the hospitals within our network of Kansas City Heart Rhythm Institute, and we have 4 hospitals that we operate out of, and we took 2 hospitals and we worked with the ER docs and the hospital administrators, where we created a protocol where when a patient comes into the hospital with a diagnosis of atrial fibrillation, if they meet criteria for hospital admission, they get admitted to the hospital, and a simultaneous consult goes from the hospitalist to both cardiology as well as electrophysiology. If they can be discharged from the emergency room, they get an appointment with our Kansas City Heart Rhythm Institute within 2 weeks of their discharge, with clear-cut instructions of being started on anticoagulation, rate control, and a rhythm control strategy if it is pertinent, and they get seen in a timely fashion. And this little tweak in the access to care, access to improving a visit to electrophysiology, really brought about a tremendous difference in outcomes, right? All the things that we talk about with new innovations and things like that, if you can fix the process, you can really come up with some tremendous changes and improvements in patient outcomes.
Beautiful. I could not agree more with, the whole process as you illustrated, looking at needs finding and looking at the process flow map, looking at where the gaps are. And in this day and age, testing these care pathways, just like any other technology or drug, as you mentioned, is so important. You're an MBA, so I'm sure you've heard this before, but culture eats strategy for breakfast, as they say. So for this specific study and for this the operationalization of this care pathway, who were the stakeholders? You mentioned administrators and physicians, but overall, how many stakeholders did you think about, and how did you get buy-in from everyone, not just for the study, but also kind of maintaining the pathway for after the study?
So I think the biggest fear is obviously your referral source, right? I mean, there is a general sense among general cardiologists who are your referral base for electrophysiology, thinking that somehow you're preempting their role in this whole process. And I think that fear has to be mitigated first if you really want to do a system-wide implementation of a practice like this. So we sat down with our general cardiology colleagues and we explained them that this is in no way taking away their role as the primary cardiovascular service provider for these patients, right? As we are very well aware, the vast majority of patients with atrial fibrillations also have other cardiovascular conditions that need attention, whether it's coronary artery disease or hypertensive heart disease, valvular heart disease, and I mean, you name it. There are so many aspects of it, and that's the reason why it is a co-management strategy where, irrespective of how a patient comes into the system, right, whether it is through cardiovascular services from a general cardiologist's office or it's through us, they still need to see a general cardiologist because risk factor modification and addressing other facets of their entire cardiovascular disease profile, I think, is equally important. And that's one biggest stakeholder that you need the buy-in from. And once we went through this process and we really showed them what can be done, it was relatively easy to really get their buy-in, right? And then you need emergency room physicians who are actually thrilled to have a resource at their disposal because they don't know who to send these patients to. So when they have one number to call for all patients that are coming in with atrial fibrillation, they're more than thrilled to actually have the resource on hand. So their buy-in was relatively easy. And then you have the inpatient services that really need to figure out. So talking to the hospitalists and others, that creating that process in people's mind, I think, is important. And this is where your service line directors can be super helpful, right? So your chief operating officers in a hospital, the service line directors in the system, both on the inpatient and on outpatient side, they all have to come together to really create this process. You can leverage electronic medical records. So when a patient with atrial fibrillation comes through the emergency room, there is a reminder, have you consulted electrophysiology, right? I think that's a very simple drop-down button. So they can say yeah or nay, and then you push a button, and then it's included as part of the whole workflow. So the cardiologists, the service line directors, the hospital CIOs, and the emergency room directors and physicians, along with your own electrophysiology team members that should be willing to really carry on this burden, right? So, and I think for practices that are well lined up, that have resource pool where you are able to see these patients in a timely fashion, I think it cuts down on so much of the riffraff that the patient has to go through. So, when you really put all of these things together, you will cut down the time that a patient takes to get into the hands of an electrophysiologist by several months, which would have otherwise been what the issue is. Time to anticoagulation, time to the initiation of antiarrhythmic drugs. Getting patients into effective rhythm control strategy, I think, is just tremendous, right? As a result of which, your time to catheter ablation is also significantly shortened. And what does this do to patients? Patients get back into rhythm much faster. The quality of life improves tremendously. The risk of AFib-related complications, which is strokes, TIAs, bleeding complications, the ability to come off of antiarrhythmic drugs as well as anticoagulation is significantly shorter. And all of this leads to decreased hospitalizations either for heart failure or atrial fibrillation or AFib complication-related hospitalizations. which in turn translates into less number of days spent in the hospital and tremendous amount of healthcare dollar savings, right? So I say it is a win-win however you cut it. Number one, patient gets the best care in the shortest duration possible. They don't have to endure complications of the disease. And hospitals do well because they're actually able to save those beds for somebody that actually needs them. And then in the end, the healthcare systems win because we're spending less money on taking care of these patients.
Absolutely. I mean, I couldn't agree more. I think the idea of, first of all, going from the chief operating officer's job, often this is like the chief repeating officer. So kind of maintaining these pathways and showing sustained value is very important and helpful. And in this case, everything that you've outlined is all evidence-based. It's all early rhythm control, anticoagulation, all of these things. We have data from large trials for so long, but this is a really good example of how when the rubber hits the road, it's all about implementation, and that takes a village. And I congratulate you on having brought that village together, and I hope we could see more examples of this. So in your point of view, what is the scope of other care pathways, just like ER to EP? There's other areas I'm sure that you've thought about where these pathways can be useful and improve access and quality of care for patients and decrease healthcare costs in the country, because it's really a pressing crisis. I think in a fee-for-service model, we often don't think like that. As a proceduralist specialty, I think we tend to think more about the fee-for-service model still, but I think as you said, in the long run, we really have to pay attention to healthcare costs and value-based care. So what are some other ideas along these lines that you've had?
And I think there is always a dichotomy of thought as to who should see a patient first and how do you really navigate patient care, right? I mean, there is a section of healthcare economists that believe that every patient has to go through a primary care physician, and then you really have to leverage the triaging process that comes through, that is upheld by a primary care team, and then really take them to a specialist. I think medicine has evolved so fast and so far. Access to some of these technologies that can really make a humongous difference in shortening that time to therapy really force us to rethink how we need to structure, right? We don't have to follow the traditional models that somehow every patient has to see a primary care physician before they have to seek specialist care. I think that's an old model when technological developments and innovation was way behind, right? In an era where we have access to information, technology has improved and changed by leaps and bounds. We have machine learning and AI algorithms that can identify high-risk patients. There is no reason why we should stick to that old concept of everything has to go through a primary care physician or through a specific pathway. If we can create opportunities at the entry point of a patient that actually comes up with a problem, and you have a reasonable understanding of what they're dealing with, that patient has to be connected to a specialist as soon as possible. Either a process change or electronic medical records or anything else that you can take into consideration, right? A classic example is AFib, as we tested out in that. And then you also have other diseases like cardiac dysautonomia is a major problem, right? If you can identify a cardiac dysautonomia patient and you can get them into the hands of a specialist, you will cut out so much of wastage of resources that are in between. The same thing happens with arrhythmogenic myocarditis, right? You have a lot of patients who actually present with symptoms of myocarditis that oftentimes don't really get to the specialist care that they need to, right? You can simplify the processes that you find in this. Heart failure is a classic example of that, right? I think so. If we can identify these specific disease categories, which are high dollar consumers, high system process burden holders, and simplify their care pathways, transitioning their care from the point of contact quickly to a specialist, I think we can bring about a tremendous change in the way we take care of these patients with a lot of money that is being saved in providing for them, right? So that's how I think we should be thinking about it.
Amazing. And it's quantifiable. You can show those cost savings with direct translation of, as you said, beds saved, length of stay, heart failure hospitalizations. And we have data on this for early ablation, early rhythm control. And I could not agree with you more regarding the use of AI. And these don't even have to be very elaborate algorithms, predicting cost bloom for a patient, for example, or saying this patient should be triaged first versus the other. Before we realize the ultimate dream of platform thinking for an individual patient, I think on a group level, on a population level, there's just so much low-hanging fruit that can really help our patients and health systems. So thank you so much for joining us today and sharing your wonderful insights. Any parting message for our EPNomics audience today?
Well, I say, I mean, if you haven't implemented ERTP in your health system, please do embrace it. And I'm always accessible to you. You can find our paper on Jack EP. So happy to chat further. Whoever wants to implement this.
Excellent. Thank you so much. For more episodes of our brand new series, EPNomics, follow Heart Rhythm TV on YouTube, LinkedIn, and X. Thanks for watching.